All right. Hi, everybody. This is Shari with the Live with Purpose Health and Life Coaching. And I am so excited all of you are here today. Come in to the group, say hi, let us know you're here, drop it in the chat below. You are in the Finding the Calm in the Chaos group. And as this group knows, we do a lot of talk about how different things affect our lives and our health in this group. And today I'm so excited to have back my friend and my provider, Jessica Ham. She is a graduate from Southern Illinois University and with her master's degree in nursing. And then in 2017, she completed a fellowship in metabolic and nutritional medicine. And she is board certified and family nurse practitioner, as well as in anti-aging and regenerative medicine. Her experience is very diverse. She's worked in rural family practice, in women's health. She's been a provider for active duty military members and their dependents. She's been the clinical director for a free and charitable medical clinic here located in Pensacola. And while she was clinical director at Health and Hope, she was also part of the clinical teaching faculty for Florida State University College of Medicine. So she served as a board member and medical advisor for numerous philanthropic, the SOFA missions, I guess is what it's called, SOFA missions. It's an organization that aims to combat the veteran suicide crisis. And really, Jessica developed a passion for root cause medicine when a close family member suffered some debilitating symptoms that traditional medicine couldn't find answers to. So she personally understands the frustration that many of us face as patients when we feel we're not getting answers from these unexplained symptoms that go undiagnosed. So I'm so excited. Jessica's helped me personally. I've referred her clients. She's been in my Nurse with Purpose group coaching group and does some teaching in there. So I'm just so excited. Jessica, welcome.
Thank you.
Yeah, it's so great to have you. We've had a number of conversations, and we were just talking before we went live here, just how much our lifestyle and everything affects perimenopause, menopause, and the postmenopausal changes. So I'm wondering if you can, I'm going to go ahead and I'll put this graphic you shared, which I think is such an amazing graphic to explain this. And then you just take it from there and give us some wisdom here. So.
Yeah, so I figured I'd just kind of start with just a brief explanation of the physiology of perimenopause. And so this graph that I copied from a conference that I went to this fall, I have since taken this little visual and blown it up and put it on my bulletin board in my office, because I'm a visual learner. And I feel like when I see this, I'm like, okay, this kind of explains what's going on in those critical years, usually, from 35 on. So if you're just looking here at the little graph, you can see testosterone in men has a very gradual decline, starting at 25 years old, all the way through 75. And then progesterone, you'll see starts to have a pretty precipitous drop starting around mid 30s to 40 until they reach menopause, which is average age about 50. And then you see estrogen, which probably around age, early 40s usually has this kind of crazy up and down pattern until it ceases right around 50 to 53. So, that one particularly is the one that I kind of chuckle at when I see that, because, when women are just feeling all over the place, 1 month they're feeling like they were in their, 20s and 30s, they got breast, where they're having higher estrogen levels, they're having breast tenderness, they're moody, they're bloated, versus the next month where it's really low and they have a real light period. They're having brain fog, hot flashes and night sweats because their estrogen is low, and it's just kind of bouncing back and forth from month to month. I just feel like that visual there is helps a lot for women when we're kind of explaining this, and it's kind of like that aha moment, like, wow, okay, that's where I'm at. And that point where you see that up and down, up and down, up and down, that's where the majority of prescriptions for antidepressants and anti-anxiety medications end up being prescribed in women. 80% of prescription antidepressants and similar type medications are prescribed in women after the age of 40. So, you know, we were just talking about this, you know, rather than, you know, slapping kind of a Band-Aid on some of those volatile symptoms, you know, why don't we address the root cause, which is just this, you know, natural hormonal shift that's going on. So you can probably take that down if everybody is.
Yeah. And I have to just, you know, I came to see you actually, you know, I'll share a little bit of my story. And I know women in this group, you have your stories too. And this is so common to go to your medical provider, and he was ready to prescribe me one of the antidepressants that I was feeling fine in that area. I was like, can I do something else? He's like, well, this is going to help your estrogen level. And I'm like, can I do something else? So it's such a key, important piece of like, what can we do? What's going on? How is our lifestyle related to all of this? And what can we do in that piece? So,
well, and the good news is, I think, you know, in years past, the approach used to be, well, you know, this is menopause and perimenopause, just suck it up, you know, and we've evolved, and the science has evolved to understand that there's a lot of things we can do, both natural first, and then, you know, sometimes we have to go the prescription route, but there's a lot more things that we can do naturally to combat some of these extremes and symptoms. So, and there's just more awareness. And I think, you know, people that focus on hormone replacement, you know, that's the more personalized approach, you know, unique to each individual, because not, you know, from one woman to the next, their experience is going to be very different depending on their lifestyle, their body composition, you know, their exposures. Yeah.
So, you bring up a great point in hormone treatments, and I know we're going to get into that a little bit, is talking about that. And I think the importance of like something that I've come to understand working with you is like, it is not just a here you go, set it and forget it kind of approach. It is one of those things where you do have to check in. Having that routine blood work done, it has been such an important piece, I think, in tracking what's been going on and those signals. So
particularly in the perimenopausal phases, when you have that up and down, we may have to make alterations and tweaks. Once you've achieved menopause, it's more of a, you know, steady state. We're just coasting. But especially in those, you know, 40 to 53, there may be, you know, lots of alterations and changes.
Yeah. And I think I want to circle back to the lifestyle piece here, because this is that time in our life when we have all those crazy things going on. We maybe have more demands on us with our kids at different ages, experiencing their own stress in their lives. We have maybe aging parents that we're trying to take care of and answer their needs. We have, you know, just different things in our careers, maybe that's going on, in our just overall, a pandemic maybe happening.
Right.
So I'm wondering if you want to speak into the lifestyle and what are some shifts or some things we can think about what's might be affecting.
Yeah. So the first hormone that starts to decline, as we saw in the graph, was progesterone. And that's usually in the mid-30s. And that helps to explain why fertility starts to decline at that stage, because progesterone is the pregnancy hormone. It's the hormone that supports particularly the first trimester of pregnancy. So around 35, we don't have as many eggs to produce. And from month to month, ovulation is not necessarily as regular as it used to. Occasionally we're kind of, putting out empties, if you will. And so the majority of progesterone is produced in the corpus luteum, which is in the egg. So if you didn't ovulate that month, then you're going to have a significant decline in progesterone. And so the most common symptoms that women experience when progesterone starts to decline is usually going to be during the luteal phase of the cycle. So you have 2 stages of a menstrual cycle. You have the follicular stage, which is from day 1 of your menstrual period until the time that you ovulate. And that is when estrogen is most dominant in the cycle. And the role of estrogen is to build that lining within the uterus that's rich in blood and nutrients, so that if an egg were to be fertilized, it would have a nice wall to implant in that's, has a great rich blood supply. And so progesterone, once we ovulate, its role is to support the endometrium. And then, if the egg is not fertilized, it has a lifespan of, 7 to 14 days, and then it will die off, and then the lining will shed. And so progesterone, when it starts to decline in the luteal phase, which is generally going to be from ovulation until the time that you start your period, insomnia is a big one, and anxiety. So 2 of the big ones are going to be insomnia and anxiety, in the majority of patients. And so that can be really, sleep is huge. When you think about the ripple effects that poor sleep has, if you have, a week to 2 weeks out of every month where your sleep is disrupted, and I can speak to that because I'm currently, I'm 43. So I'm in that perimenopausal stage, and probably in the last year to 2 years, it's kind of, initially it was hit or miss. I would be sleeping great for a couple months, and then all of a sudden, I would have a month where it was like, it took me a while to figure out what was going on. Even being someone that works in the field, I would wake up at 2 or 3 o'clock in the morning and not be able to go back to sleep. It wasn't so much falling asleep, it was staying asleep that became an issue. And so now I use progesterone during the luteal phase. So right around the time that I ovulate, I will start taking progesterone until the point that I start my menstrual cycle, which significantly helps with the insomnia piece. And on the subject of sleep, just talking about the effect that poor sleep has on the body. Clinically, we know that less than 7 hours of sleep increases your risk of obesity by 70%. And just think about, a poor night of sleep. Generally it leads to mood disturbances, you're snappier, you're edgier. It leads to poor food choices. You're reaching for more comfort foods. If you're fatigued and you're not feeling so great, you're much less likely to engage in healthy behaviors like exercise. You just kind of want to take a nap. Sleep apnea is something to address in this age group. If you're waking up and you stop breathing, your partner, says that you stop breathing, that should definitely be addressed first and foremost. And it becomes an issue because body composition starts to change at this stage. When we're more estrogen dominant and we don't have progesterone to support, the elevation in estrogen, then our body composition starts to change and we put on more weight, particularly in the belly, and that's going to increase your risk of sleep apnea. So that's something that also tends to pick up, in this age group. You don't typically see people in their 20s and 30s that are, sleeping with CPAP machines. It's usually, 40, 50, 60, just because some of those changes. So, and then, in light of our pandemic, when we don't get good sleep, it affects our immune system. Our immune system is suppressed. We're less resilient to the different viruses and bacteria that are spreading around us. So the ripple effect of poor sleep cannot be, overstated. And so, of course, progesterone is one thing that we can do, during the luteal phase, is to support the decline and using progesterone. But there's other things, I think as a society, we've got this 24-hour, 7-day week, can go Walmart shopping, can shop online. We're just kind of this go, go, go mentality, don't ever stop. So we have to start to look back to the way that we treat our toddlers and focus on sleep hygiene. No caffeine in the late afternoon. Don't be eating too close to bedtime. Your stomach should be empty when you lay down to go to sleep. So I usually say 2 to 3 hours after eating before you go to bed. If you're going to exercise earlier in the day, because that's going to raise adrenaline levels, which can inhibit sleep. Blue light filtering glasses for, looking at devices or watching TV, because we know that blue light that's emitted in the can inhibit proper melatonin production in the pineal gland in the brain. Things like taking a hot bath or meditation or herbal teas like chamomile. These are all natural things that we can do to help promote better sleep.
Yeah. And I love what you're saying here, because this relates to everybody, not just women, but everybody. And if you are not, if you even have this in your household and you see, just step back, not with some judgment, but curiosity of what's going on in your household. Is there an extreme amount of stress in your everyday lives? Is it that you have this pace? It's what do you need to say yes to? What do you need to say no to? It's all those things we go back to of, just establishing some better habits of what our body really needs and what our body's craving for. And I love that you brought up the whole fact of immunity, because our gut health is so tied into our hormones. And so I don't know if you want to speak on to that a little bit.
So when we talk about, we talked about progesterone starts to decline. And so it leaves us in an estrogen dominant state. So when our progesterone is here and estrogen is still up here, that's an estrogen dominant state. And so things that can occur at this stage, estrogen dominant conditions are going to be like fibrocystic breast disease, fibroid tumors in the uterus, which are benign tumors that oftentimes end up causing heavier periods or more cramping with periods. So in order to combat that aspect, if progesterone is not something that's an option for you, there's a lot of lifestyle things that we can do. People don't realize how much estrogen is in our environment. And that's a term called xenoestrogens. They're chemicals and compounds in our food, in our water, in our self-care products that are just exploding everywhere. And we could have a whole separate talk on the topic of xenoestrogens and how it's affecting society today. From, just the discussion of how men's testosterone levels have declined about 25% in the last 30 years. Likely, the environment is a big piece of that, and how much estrogen is circulating in our environment that we're being exposed to. And when these compounds enter the body, molecularly, they look like and they mimic estrogen. And so then we have more free estrogen floating, in our body. And so things that we can do to avoid that is just having a general awareness of what types of things. Plastics are a huge one. So I usually, give all my women in this, age group the lecture about avoiding heating foods in plastics. So it's okay to store food leftovers in plastic, but if you're bringing them to work, then you should transfer them to ceramic or a glass container. So sometimes it's just easier to go to the store and get the Pyrex mix of bowls to bring leftovers in. No plastic water bottles. So those plastic water bottles that we grab because we're trying to be so good about staying hydrated, we don't know how long they sat in a warehouse, at 100 degrees, but that BPA that lines the plastic water bottles, when it's heated, it leaches into the water, and then we're consuming that. And it's gotten to the point where we're seeing several species of animals, amphibians, frogs, fish, alligators in the Everglades that are being born as hermaphrodites with both male and female parts because of their exposure to plastics that is being run off in the waters that's surrounding them from water bottle plants, as well as the label for young girls. Precocious puberty means developing secondary sexual characteristics. It used to be 10 years old was considered precocious puberty, and anybody less than that who's presenting with these symptoms would warrant an endocrinology referral. It is now 7 years old.
Wow.
So, and that is absolutely environmental. So going back to what we can do, especially if you have young girls that you're raising or young boys, dairy and meat products, if you can go organic on them, because they're pumped full of hormones to get them to market quicker. They want to grow them as fast as possible so that they can get them to the slaughterhouse. So they pump them full of hormones and steroids as well. So if you can, dairy and meat products should be organic. When it comes to produce, the Dirty Dozen, which is produced by the Environmental Working Group, is the 12 most heavily laden foods covered in pesticides and herbicides. And pesticides and herbicides are considered xenoestrogens. They mimic and look like estrogen in the body. So generally the list consists of greens and berries. If you think about things that have a skin that's easy penetrated, those are going to be things that we should try to purchase organic, as opposed to the clean 15 are usually foods like some of the cruciferous vegetables that have a very waxy outer coating. When you run water over them, it just kind of runs off. They're less penetrated by these types of compounds. Bananas or oranges, things that have an outer core that you have to peel, are generally more protected. So, trying to go organic. Cruciferous vegetables is a class of vegetables that have a compound in them that helps us to metabolize and excrete estrogen out of the body. So it's called DIM, diethylmethane, and the vegetables consist of like broccoli, cauliflower, kale, Brussels sprouts. So a lot of times if I have women that sometimes they have a genetic variant, that means that they don't properly excrete estrogen out of the body. I will encourage them to consume at least a cup a day of these vegetables.
Yeah.
As well as fiber. Fiber is another way to help excrete estrogen out of the bowel, because it's usually excreted through the liver, which then goes into the bowel and excreted in our bowel movements. So fiber and cruciferous vegetables are things that we can consume.
Yeah. And this is so good because this is the conversation I know that I needed with the vegetables and with the fiber, because too much information here, but I think this is a common problem, constipation, when we get into this. And what I have connected so far is when I have those days that I'm constipated, it might be that I just don't feel right, but I also don't sleep right. My hot flashes are a little bit more. So I have gotten into the habit of having these regular vegetables, and how important it is that it's something so simple that we can do. It's bringing this stuff in. And I'm glad you brought in all the estrogen dominance conversation here, because this is something I think that, a lot of times we just think, oh, we're just putting the trust in a lot of our food, FDA and different things. And yes, there are governmental organizations that do, have a certain level that they keep our water toxins and stuff, but sometimes we can do more to really address that. And I know water was one that we really addressed in our own household there too. And so
you can get a reverse osmosis system, install it under your sink. It's about $250 from Amazon. I use the Apex system, and whenever I leave the house, I fill my fancy little, stainless steel water bottle instead of purchasing, plastic water bottles.
Yeah.
And you'll recoup the expense in a year from not buying plastic water bottles.
Yeah, I have the same thing. I did the HydroVive system, which is something that you install, same kind of thing. And it is taking those extra chemicals that you're getting into your body and how that shows up in all these chronic diseases, what it leads to is very eye-opening. So just kind of really going more with kind of the going back to like menopause and post-menopausal as we make these changes in our bodies and stuff, is talking about, I want to touch on the hormone treatments. Like, what are some options if somebody comes in and says, you know, I guess more of a traditional, what has always been done versus what are some of the things, bioidentical hormones, that kind of thing.
Sure.
I'm wondering if you can speak to that.
So in the perimenopausal patient, which is a woman who's still menstruating, generally progesterone is going to be the agent that we're using. In some women, we may also use testosterone. If their major complaint is poor libido, then that's the only approved indication for testosterone in this group. So progesterone generally is used orally by mouth. And there's actually the bioidentical form is produced by pharmaceutical company under the name of Prometrium. And so that's the agent that I generally use. It can also be used topically in a cream that can be compounded at a pharmacy, compounding pharmacy. However, my preference is to use oral because it crosses the blood-brain barrier and it has better effectiveness for the insomnia and the anxiety piece. So, and there's more clinical data on actually protecting against uterine and breast cancer and oral progesterone use. So for the most part in this age group, I use oral only. And then, you know, at the point where women reach menopause, which is defined as the cessation of period for 12 months. That is the most consistent, you know, way to identify that a woman is menopausal. A lot of times after that, to confirm, we'll draw some lab levels, an FSH and an LH. Those are the levels that are being produced from the pituitary, telling the ovaries to produce estrogen and progesterone. And they tend to go really high once a woman has achieved menopause, because it's like the pituitary is saying, hello, hello, how come you're not answering? And so it keeps producing more and more because it recognizes that the ovaries are not producing. So that's a secondary measure of how we'll confirm that a woman has gone through menopause. And I always want to throw this out there, because if you've stopped having periods for 12 months and then you start bleeding again, that's never normal, and that should always be evaluated. So when a woman who goes through menopause, traditional hormone replacement would look like something like Prempro, an oral conjugated estrogen, and that just means conjugated estrogens are produced from a pregnant horse's urine. So that's kind of the traditional approach that's been around for years and years and years, mixed with progestin, which is a synthetic progesterone. So, you know, we could go back to like Women's Health Initiative in the early 2000s and the study where, you know, prior to that, almost, you know, most women were on hormone replacement because we knew there were, you know, great benefits in terms of like osteoporosis. And then they had this study and it was very poorly designed and it ended up being turned over, I think like 2018. You know, North American Menopause Society put out a position statement and, you know, they reviewed, you know, all the data and it was poor selection of patients. The average patient in the trial was 63 years old, you know, smokers, overweight, they were using synthetic forms as opposed to, you know, like progesterone or Prometrium, which is more breast protective. So there were a lot of faults in the study. And so for a long time, women were being taken off of hormone replacement because it was showing increased risk of cardiovascular events. But they've since looked at all of these, you know, the poor design in it. And now the consensus among most groups, particularly North American Menopause Society, is that starting at menopause, which is generally between 50 and 53, the benefits of hormone replacement outweigh any risks. And so now the approach is that between the ages of 50 and 60, that's really when hormone replacement is going to be most strongly encouraged. The best time to start it is immediately upon going through menopause, because that's where you're going to achieve the most benefits in terms of brain health. For instance, as we lose estrogen, the brain actually starts to shrink, and we start to see cognitive decline as early as in the 40s. And that's, the brain fog, where you're like, you just can't seem to put thoughts together like you used to, or you're more forgetful. And so starting hormones right at, the age of menopause significantly reduces the risk of dementia or cognitive decline. It also, estrogen has very protective effects on the cardiovascular system. So when we think back to 20 years ago, the standard recommendation used to be that men at 45 were to start a baby aspirin and women at 55. And the reason in that 10-year gap is because how protective estrogen is to the cardiovascular system. And so by 55, because women have, been outside of menopause for usually 5 years, they have finally reached the same risk profile as men. And so maintaining estrogen levels in the 50s helps to decrease cardiovascular risk. So, the approach that I have is when women come in their early 50s and, they're struggling with the hot flashes and the night sweats and, the brain fog, the body composition changes, we'll discuss hormone replacement. It's always going to be a combination of estrogen and progesterone. They always should be given together. If you give estrogen without progesterone to a woman that still has a uterus, then you're potentially going to grow a lining, and you increase the risk of uterine conditions. So they're always given together. The one that's kind of questionable is testosterone. That's just dependent on the patient and, what their levels look like. So the traditional approach, being the PremPro, we don't use in our practice because we know that oral progesterone has a lot of adverse effects because it has to filter through the liver. When you take something by mouth, the first pass effect as it goes through the liver, particularly with estrogen, has a lot of detrimental effects. It can increase inflammatory markers like CRP, it increases triglycerides, it increases blood pressure. And so when you bypass the oral route and use it transdermally through either a patch or a cream, then you don't have to go through the liver. And so we avoid those effects. So in our setting, we would always use estrogen topically. And I know it's probably confusing because I said progesterone, we take by mouth. Progesterone by mouth does not have those effects.
Okay.
So it's only estrogen.
Yeah.
So estrogen taken transdermally, we avoid a lot of those detrimental effects. And then when we talk about bioidentical estrogen, it means that it's the same chemical structure as what we're born with, as opposed to using, a pregnant horse's urine. The receptors aren't exactly the same. And so our issues generally are in metabolizing it. It lingers around in the body longer. And so we want to avoid that. So bioidentical estrogen in the US is usually produced from actually yams. So when it's compounded at a compounding pharmacy, they're using it from yams. And then we usually use a combination of two types of estrogen, estradiol, which is the one that we're most familiar with. It's the most potent estrogen that our body produces, but we also use a compound called estriol, which is a weaker estrogen. And we use it because it's protective for the breast. It generally fills the receptors in the breast, and it protects us from our own physiologic production of estrone. So there's three types of estrogens that we have. Estradiol, which is our most potent, the one that we're all most aware of. Estriol, which is a very weak estrogen, but it has a lot of protective benefits for the breast. And it also has a particular affinity for vaginal tissue. So the women who have the vaginal atrophy symptoms, dryness, lack of lubrication, painful sex, lots of urinary tract infections, estriol is a great tool for them. So in our setting, we always use a combination of estriol and estradiol. Nice. No one ever prescribes estrone. Okay. Our body, that's what we produced postmenopausally through the adrenal glands. So even if you have your ovaries removed, you'll still be producing estrone. And the more fat tissue that you have, the more estrone you'll be producing. So we're always taking measures to lower estrone, because a lot of the postmenopausal associated cancers and conditions related to estrogen are related to actually estrone.
Yeah.
So
you were bringing up so much stuff that ladies chime in here in the chat here, how complicated hormone health is, right? When we have all of these things going on, we can go, oh my gosh. So I'm wondering, Jessica, I know when I went into my provider, there were certain hormone levels that were tested. And I'm wondering if you want to kind of describe from a functional medicine approach, just what is different about functional medicine and maybe what is tested differently.
Sure. Yeah.
That even somebody maybe can go back to their provider. It's having that conversation too with the provider who may not be familiar with testing at a much deeper level and why that's so important. So
sure. In the traditional setting, whether it's, going to your OB-GYN or family practice, because they're seeing so many patients, you're always getting a one size fits all type of approach, and so testing is rarely done, maybe for testosterone, but testing of estrogen and progesterone levels are rarely done. You just kind of get, if you're going to get, a Prempro or one of these type prescriptions, there's a few different doses to choose from. They'll usually start you kind of middle of the line, and if you get benefit, great. If not, maybe they'll increase the dose, or if you're getting too much, they'll decrease the dose. So, in our setting, we'll test, because if I'm writing for it to go to a compounding pharmacy, I'm going to write whatever dose I think is appropriate. It's not just like the 5 doses that the pharmaceutical company produces. It can be anywhere from here to here, depending on the levels and where they're at. So, we'll check levels usually initially before we initiate the hormones. And then after we start hormones, I always check about 3 months later, because it takes about 3 months for hormones to balance themselves out. And once we've gotten to a place where, we're good, we feel good, everything is in range, then the testing frequency, decreases. Maybe it's every 6 months, maybe it's once a year. It depends on where the woman is at and, the process, if they're perimenopausal versus postmenopausal. At a minimum, we will be checking them at least annually. Right? Because there's a lot of things that even, if you are postmenopausal, it can change things. A change in your weight and your body composition could make a big impact, because if you put on a lot more fat, then your body is going to be producing more estrogen, because fat tissue produces estrogen. So that's another reason to be testing and looking at that. And then I would say, there's a subgroup of women that have a strong family history for female cancers, breast or uterine. And so we want to take a more personalized approach. In a typical setting, it might just be that they say, absolutely not. We're not giving you hormones because, we don't know the risk is. In our setting, I would do more focused testing. I might look at some genetic markers, and I'll probably do something called an urine estrogen metabolism test, which we would look at how the body excretes estrogen, because a lot of our risk with female cancers is directly related to how our liver clears the estrogen. And if we have impaired liver detoxification, then that's going to increase the risk of DNA changes. So, if I have someone that, they're feeling awful, but they know their mom had breast cancer in their 50s, it's not going to be an absolutely not for me. It's going to be, let's dig a little bit deeper let's peel a few more onion layers away to see what your real risk is. So, that's why it's kind of more of a personalized approach, because it really depends on, what's going on in their life, what's their lifestyle, to determine, what are we going to test for?
Yeah, I love that, because it brings out that point of we're all different. We all are individuals, and we do need kind of an individual prescription to our life, if you will, but also like the lifestyle piece, but also the hormones, getting the testing frequently, as frequent, and having that discussion with your provider. Where especially, my own experience was just going in, here's a pill, here's the, one size fits all, but it didn't fit me kind of approach. And it is, I know both of our spouses are in medicine, and it is a system right now that is really difficult to practice in, because you are really up against time and seeing a number of patients. And that's why I was so interested in the functional medicine approach, because it does complement what I'm getting in my regular provider going to see for my annual, but I just bring a copy of my labs that you've done into the provider. And his last comment was, okay, she's taking care of that. I'm not going to address that, because there's much more at a deeper level that I don't understand. He was willing to say that, and I appreciated that, because now I know it's like, okay, I know where I need to go for this. And so I think, what would you recommend this? How do women talk about this with their providers and feel supported? Because we can go into those offices or have those conversations where, it can feel very like you're not being seen and heard, and you can leave feeling a lot of, kind of loss of hope. And so,
well, I mean, to be honest, having worked family practice myself, in a family practice setting, you kind of develop your niches, your areas of expertise. You're kind of, you have to know a little bit about everything. But, depending on what your population looks like, for instance, I did a lot of diabetes and hypertension and high cholesterol and those types of chronic conditions. If you have a conversation with your provider and, talking about perimenopause, and they kind of look at you like a deer in headlights, or they don't really have a lot of input, well, then it's probably time to move on. I mean, especially in family practice, they can't, be an expert in every area. So you might just need to seek out somebody, whether it's your OB-GYN, would probably be the next most likely place to go to. And I am seeing a lot more, local OB-GYNs that are really diving deep into this, because that's a huge bulk of their practice. But if not, then seeking out someone who's in integrative or functional medicine, would be, the last piece of where to go for sure. Because they're going to take, whether it's, a nurse practitioner, physician or naturopath, they're all going to be trained in this type of approach.
Yeah. You bring up such a great point, is like asking, you have friends who are probably going through this very similar in your area, asking who do they see, bringing up these conversations, because this is not something to just laugh about and say, oh, I'm having hot flashes, just this is the way it is. It's as you can hear from what Jessica has described over this whole period of time here, is how connected this is to other parts of your health and what it leads to, and what kind of things you can make in changes in your lifestyle, and just simply becoming aware of what are some of the things that you can do just as a first step. So I want to invite everybody here, is like, what is the thing you're walking away with that you really learned today that you want to investigate even more or put into action? It's like, just take that one first step. And so what I want to do here, Jessica, is just where can people find you if we're locally, we're in the Pensacola area? How is telehealth working now? That kind of
Sure,
thing.
yeah. Yeah, so I'm in a practice downtown Pensacola called Regenesis Performance. And, we have a website, www.regenesisperformance.com. We also have a Facebook page. I can put up our phone number to reach us, but generally a patient would make an initial appointment, fill out a pretty detailed history before the appointment. First appointments are always an hour. We dig deep, into all the way from birth on, because that's all very relevant. And then, we'll usually do a pretty comprehensive panel of labs. We're looking at nutritionally, looking at pathways of detoxification. So we'll do a panel of labs, and then we'll kind of go from there and, make a decision on what the best approach is for that patient. So, generally first visit, or at least annually, I'm supposed to see someone in person so that I can lay hands on them and examine them. But all the in-betweens can be via telehealth. So yeah, that's been really nice because it's really changed and become more convenient for a lot of people that way.
Yeah, it's so good. And what Jessica is speaking to is just like that first appointment. So, filling out that questionnaire is really giving yourself time to go back all the pieces, everything that you've been exposed to in your environment, any illnesses you've had, anything that your lifestyle is, all of that's going to be in those questions along the way. And then what some people don't realize, Jessica, is just how deep you dive into this on your own before that first hour we have together.
Yeah. That's why I usually want them to fill out the history form at least 48 hours prior to their appointment, because the night before, I always spend at least 20 minutes up to, sometimes an hour just reviewing their history so that I can mentally kind of develop, where's my focus, where are the missing links I need to figure out when I'm face to face with them, and, what am I thinking? What are their issues, I think that we need to address that are affecting, their condition just besides hormones. Sometimes, you can tell that they're insulin resistant, you can see other patterns through filling out that history piece. So that's really important.
Yeah, I think it's one of those missing points that doesn't always get done in conventional medicine right now. And there's nothing against conventional medicine. Again, it's the time piece. You take the time to go through all these and connect the dots that may not be so obvious. So yeah, spending that time. If somebody's not in the Pensacola area, and I'm going to go ahead after this live and put in your information in the chat and in the comments so they can find you. There's a couple other places I know they can find a provider that specializes in functional medicine.
Yeah, so there's different directories. Where I went and did my fellowship program was through A4M, American Academy of Anti-Aging and Regenerative Medicine, and they have a find a provider link at the top of their site. If you go to A4M's website, somewhere along the top right, there's going to be a find a provider, and anybody who's, board certified or part of their organization, depending on, by state, they'll list those providers. So does IFM, which is Institute for Functional Medicine. They also have a find a provider directory. I'm sure there's many more. You could probably just start Googling in your local area, hormone specialist or integrative or functional medicine providers, or Facebook, it's generally usually pretty easy, if you start searching and, just looking first, that they've had some type of training in this area, and the two major organizations are usually A4M or IFM.
Yeah, great. And I'll put that in the chat as well. So all of you can have that resource. Jessica, I really appreciate your time today, sharing this with everyone. Is there anything you want to leave us with before we kind of close out for today?
The only one area that I did want to hit was, combating some of the body composition changes. In terms of movement and exercise. I always put a strong emphasis that the key and the focus at this stage of life should be in strength training. Generally I'm pushing for 2/3 of the time spent in strength training, and 1/3 in cardiovascular. And that's just because the decline in lean muscle mass that occurs starting at perimenopause of 3 to 5% per decade really has a lot of ripple effects as well. So maintaining lean muscle mass helps metabolically to maintain a higher metabolism. It helps reduce the risk of falls and injuries. And so, that's another huge piece that, cannot be overstated, is making sure that we continue to move our bodies and in types of exercise, whether it's, bands or hand weights or machines or body weight, doing squats and lunges and things like that to maintain muscle mass is a huge piece as well, that we didn't quite get to. But
yeah, I'm glad you brought that up, because really kind of the 4 takeaways I'm taking from this conversation is, one is our food can really make an impact on how our hormones are affected. Our movement is another thing, knowing that our stress and our self-care and especially our sleep are one of those things that has a direct impact with our hormones. And food, again, back to gut health, has a lot. And then 4 is just see your provider, have these conversations.
Yeah.
It's such an important thing. This is an investment in your health now so that you can be the person that you want to be as you age in life. And I think, I always talk about the 3 objections that really stop us. It's time. I don't have time. I don't have money, and I don't have permission. And those are really not the way we should be living our lives. We need to address why we're feeling that way in those 3 things, and understand that when we invest time, when we invest money, and when we give ourselves permission to invest in ourselves now, it does pay for itself in the long run. So
now is the emphasis, because we don't want to work all our lives, reach retirement, and now our schedule is full of going to one specialist to another. You don't want to reach that point to have, be suffering with chronic disease. You want to be, strong and, mentally capable. So the focus is, don't wait, until you have more time on your hand. Now is the time to take care of it.
Now, that's the takeaway, girls. So if you have any questions, drop them in the chat here. Jessica and I will be on the feed throughout the next couple of days here to just monitor any questions that come in, and feel free to reach out. I have the Nourish with Purpose group coaching program. I have one-on-one clients that I work with through the support and the accountability to take your plan after seeing someone like Jessica and put it into motion and have the endurance, if you will, to keep going, because you are so worth it. So Jessica, thank you so much.
Thank you. I appreciate it.
Take care.